So now I'm going to show you the cardinal movements of labor in a breech vaginal delivery. I am not going to show you the maneuvers that we are going to do in assisted breech vaginal delivery. First, we are just going to highlight the principal cardinal movements. Those are the very basics to help us understand the maneuvers later on. Okay, so let's have a look at this baby first. Okay, so this is a frank breech, let's say, right? This is the bis-trochanteric diameter. Okay, this is between the two trochanters, right? So this is the bis-trochanteric diameter. Similarly, this is the bis-acromial diameter. And for the head, it is going to be the suboccipito-frontal diameter. That is, these three are going to be the engaging diameters of these particular fetal parts. Okay. So when we say that the bis-trochanteric diameter is going to enter the pelvic brim, this is the diameter that is going to enter the pelvic inlet during engagement, right? For that, let's have a look at the pelvis also. So when we look at the pelvis, right, left sacro-anterior. So sacrum directed anteriorly, right? So let's have a look at this here also. Sacrum directed anteriorly. So we can see the bis-trochanteric diameter. Look at this, back is anterior, sacrum is anterior, and the bis-trochanteric diameter is entering the pelvic inlet through one of the oblique diameters, the one that I'm pointing right now, right? One of the oblique diameters, it is going to enter, and then it is going to further descend, with contractions and everything as the course of labor progresses. And as it is going to enter the pelvic floor, as it is going to reach the pelvic floor, as you can see from here, the buttocks actually, they have to rotate anteriorly, isn't it? Internal rotation has to take place. So internal rotation of the buttocks takes place, right? So they were obliquely aligned, as you can see right now. And then they are going to undergo internal rotation. Okay, so when they undergo internal rotation at the level of the pelvic floor, we can see that the buttocks are now aligned in the antero-posterior diameter of the outlet. Okay, now with further contractions, what will happen is that the anterior buttock will become visible at the perineum. And then with further contraction, what will happen is that the trunk will undergo lateral flexion. See, trunk will undergo lateral flexion and the posterior buttocks are going to get delivered. Right? And then the rest of the delivery of the baby is going to follow. I am not showing you the maneuvers right now. Most of the times, let's say, this can be achieved without performing any maneuvers at all. So the breech has delivered, the buttocks have delivered, and the legs have also delivered. So this is the position right now, as you can see. Right? Now further what will happen is that there is going to be internal rotation of the shoulders. Actually, you can see here that the buttocks are going to undergo external rotation that is visible from the outside. Actually, the shoulders are rotating internally. Okay? So just to see here as well. Look here right now, the position. And appreciate that for the shoulders to enter into the pelvic brim, they have to align in the same oblique diameter. Okay, same oblique diameter as the buttocks, as the bitrochanteric diameter. So now the shoulders are aligning in the same oblique diameter, as you can see. And if you look at it from externally, you will see that the trunk is now more anteriorly placed. It has rotated anteriorly, right? So then what will happen with further contractions? Shoulders are going to enter the pelvic floor. But now for delivery of the shoulders, again what will happen? Internal rotation of the shoulders will take place. So the shoulders are going to align in the antero-posterior diameter. Okay, so you can see here shoulders have aligned in the antero-posterior diameter, and with further contractions, the posterior shoulder will get delivered. Okay, the anterior shoulder will also get delivered, and we will have the head that is still inside, as you can see. Right? So we can see that the head is still inside, right? Now, as and when the shoulders are descending into the perineum and they are delivering, it is at the same time around that the head is also entering into the pelvic inlet, isn't it? So the head is going to enter the pelvic inlet either in the transverse diameter, as you can see here. See, this is the suboccipitofrontal diameter. I'll just hold the head like this. Suboccipitofrontal diameter, it will enter either in the transverse diameter or it will enter in the opposite oblique diameter. See? So what we see anteriorly happening is that the trunk again, you can see, becomes anterior. That's because when the shoulders had delivered, it was like this, right? Shoulders had delivered, the back of the baby was facing the left side of the mother, all right? And now, as the internal rotation of the head will take place, right, you can understand that the back will also become more anteriorly aligned. So, we are seeing the external rotation of the shoulders on the outside. Actually, what is happening is that there is internal rotation of the head is taking place and the head is going to enter the pelvic inlet in the opposite oblique diameter, right? Opposite oblique diameter of the inlet, right? So, further on, what will happen? Internal rotation of the head will take place. So, internal rotation of the occiput, right? So, the occiput comes to lie underneath the pubic symphysis. And after this, the head will be borne by flexion. So, I'll just have to hold the baby from here to help you understand that the head will deliver by flexion, right? So you can see here, first the face will come out and then lastly the occiput, right? So these are the cardinal movements that take place, right? What are the cardinal movements? Internal rotations of the buttocks, internal rotations of the shoulders that are taking place, the head getting engaged, right, and the internal rotation of the head taking place. All this while, the thing that you should have been able to appreciate is that all this while, the back has to remain more or less anteriorly aligned, right, to allow for the vaginal delivery to take place, isn't it? So, I hope that these cardinal movements are simplified for you now. When we're going to talk about the method of delivery, I am going to touch upon these very aspects little bit more in detail. So now we're going to see how breech vaginal delivery is conducted, how it occurs with the help of a gudda and pelvis, right? Now the principles of the cardinal movements, we've talked about them earlier. We are now going to combine it and we're going to see how clinically it is done, all right? So just recapitulating what we've already discussed in the lecture so far, okay? Now talking about left sacro-anterior position, okay? So sacrum directed anteriorly on the left side of the mother, sacro-anteriorly. This is the bistrocanteric diameter, which is going to be the engaging diameter of the buttocks, right? Now, have a look. Now, this bistrocanteric diameter is here and this is the leading point of the buttocks. Now, the distance between the leading point of the buttocks and the engaging bistrocanteric diameter is much less if you compare it with what is the corresponding distance in the cephalic presentation. So in the cephalic presentation, if you have a look at it, this is the leading point of the skull and this is the biparietal diameter, let's assume, okay? So this distance is more as compared to in breech. What is the significance? The significance is that as and when the buttocks are going to reach the level of the ischial spines, the leading point of the buttocks reaches the level of the ischial spines, we can very well assume that the buttocks must have gotten engaged. That means the bistrocanteric diameter must have crossed the pelvic brim. That is the significance, okay, in determining the engagement. So, coming back. So, this is the bistrocanteric diameter. As you can see, it is going to enter the pelvic brim along one of the oblique diameters, right? Bistrocanteric, one of the oblique diameters like this. This is entering the pelvic brim. With contractions, it is going to get pushed down. And then what is going to happen at the level of the pelvic floor? Anterior rotation of the buttocks is going to take place so that the buttocks can now align along the anteroposterior diameter of the outlet. Now, with further contractions, further descent of the breech is going to take place. So I'll have to like just let it push a little, right? So if you look at it now, what will happen is that the bis-trochanteric diameter here, it will become visible, right? The anterior buttock will become visible. The bis-trochanteric diameter is now emerging out of the introitus. After this, what will happen is that with further contractions, lateral flexion of the limb, right, the posterior buttock is generally what is going to deliver first. So most of the times, nothing needs to be done. So let me just deliver out the posterior buttock for you. Okay, so posterior buttock, let's say, got delivered, and the posterior leg also got delivered on its own, right? Now, I'll just have to turn this a little bit so that I can show you how the delivery of the leg can be assisted. Sometimes the delivery of the leg needs to be assisted. Like if you look at this here, this is the extended leg. We will go along the femur, okay, along the long axis. We have to avoid putting traction along transversely or perpendicularly on the long bones, right? So we go along and then we externally rotate. Okay, let's just hold it steady. Externally rotate. Okay, at the level of the popliteal fossa right here. So I'll just have to detach it from here so that is ease. So I'm pulling from here, okay, externally rotate the hip to deliver the leg. And then focus is on keeping the back anterior. So we are going to support it. Look at this, holding by the sacrum and fingers along the iliac crest, right? Just trying to keep the back anterior. So once the back becomes anterior, once the back becomes towards the anterior, we can see here that the shoulders are now aligning in the same oblique diameter as the buttocks had entered the pelvis. So the shoulders are now at this point in time going to enter the pelvis along the same oblique diameter, right? So that is a very important clue. The back remaining anterior, the back turning from lateral to anterior. That means this external rotation of the back that we are seeing, okay, from lateral to anterior. That in itself is a sign that the shoulders have descended into the pelvis. Very important clue. So we are actually maintaining the back being anterior. Okay, we take the umbilical cord along the side. Okay, now with the second contraction, we are expecting that as and when the next contraction will come, further descent is going to take place. You understand, we don't have to, pull or tug from below. We just have to support and maintain the back anteriorly. We are anyways expecting that internal rotation of the shoulders is going to take place, right? So internal rotation of the shoulders that takes place is going to align the shoulders along the anteroposterior diameter. The shoulders have to align along the anteroposterior diameter. So now the shoulders have gotten engaged, right? And we are keeping and maintaining the back anterior, okay? And now we have to deliver the shoulders. What did I tell you will be the clue? That the axilla should become visible and that scapula will slightly bulge, okay? So considering that the scapula is slightly bulging and I'm expecting that this is the axilla that has to deliver, with the next contraction, see, with the next contraction, I am expecting that internal rotation of the shoulder should take place. That is exactly what I'm also going to do and promote at the same time. So I'm going to turn 190 degrees. Look at this clockwise. And this will make the shoulder visible. Okay. Then I can go along the length of, the humerus and then hook out the elbow to deliver the arm. Okay. Then I will rotate the baby. I will do it like this, but I will like this, okay? So now you can see here the other shoulder becomes visible, it becomes accessible, and then I can go along the length of the humerus to hook out the arm like this, and then keeping the back anterior, okay? Now, this is basically the Loveseth's maneuver, to deliver the arms. and shoulders. It also helps in preventing any extension of the arms and any nuchal arms at the same time, right? Now, sometimes this rotation of the baby may not be possible, and then how to deliver the shoulders then at that point in time. So I'll just put the shoulders back in. Okay, I'll just put the shoulders back in to help you understand, right? So look at this. Now the shoulders are aligned in the antero-posterior direction, okay? And I was supposed to keep the back anterior, but now sometimes what can happen is, let's see, we can see here that the shoulders are aligned in the antero-posterior diameter. And sometimes this anterior shoulder may not be accessible. Sometimes this anterior shoulder may not be accessible to deliver. Then one can deliver the posterior arm instead. So for that, we lift up the baby like this towards the opposite groin. And, you know, then we can go along the humerus to grasp the elbow and hook out the elbow and deliver the posterior arm first, taking advantage of the fact that posteriorly there is more space in the pelvis. And then, you know, it will give us more space to deliver the anterior arm, going along the humerus and hooking out the elbow. So this can also be done. So these are the two ways that, you know, shoulders and arms can be delivered. So you use whichever method you are more convenient in, okay? So now we are holding the back anterior. The umbilical cord has been pulled to one side. Avoid any pulling or pushing. At the same point in time, we have to ask the assistant to give any suprapubic pressure to maintain head flexion. Any maneuver to deliver the head should be started once the nape of the neck is visible. Okay. Now, this would be one good opportunity to look for, you know, the signs suggestive that the fetus is healthy. Okay. Like for instance, a fetus that is doing well, tolerating the stress of labor well, because some or the other degree of cord compression is likely in this situation, right? So fetus's hands are moving and the tone is there. That's a good sign. There is, reperfusion of the fetal skin during the, conduct of delivery. You'll notice that the fetus's buttocks and the, and the back and the trunk, umbilicus, everything gets blanched while the delivery is happening. If now at this point in time the baby is nice and pink, reperfusion is there, that means baby is getting, good enough oxygen. So that is a good sign. After we delivered the shoulders, the shoulders delivered in the antero-posterior diameter. After we delivered the shoulders, if the back, it is easier to get the back in the anterior direction, right? That means that head has come down into the pelvis. So that is a good sign. But if the back, remains lateral, let's say, that would be a signal that maybe the head is still high. It has not come down into the pelvis. So make a note of that also, right? And also note, sometimes it may be possible, especially when, any undue traction, any undue pulling has been done to deliver the baby, it can lead to extension of the arms. Right, that can happen. Now, in that situation, what will happen? If the arms get extended, then the shoulders will, maybe not descend into the pelvis. So what you have done is probably delivered the legs and delivered the trunk, and then maybe undue traction has been applied, and that has led to extension of the shoulders. So what you will see is that because the shoulders are not descending into the pelvis, you see the rotation is not taking place, right? So it is like this only. Okay, so for shoulders to descend the pelvis, they have to align in the oblique diameter. That would mean that externally we are going to see the back coming anterior. If the back remains lateral, it's not coming anterior. We are trying, maybe it is becoming difficult. We are pulling too much. That is creating problems. Creating problems in the sense it can lead to extension of the arms. And this fact could very well signal, this information that the back is still lateral, it is not coming anterior, could mean that the shoulders are getting stuck at the level of the pelvic brim. If all of this doesn't happen and delivery of the shoulders and arms can be achieved with ease, as with the maneuvers I had shown you. That's one important point to note. Second, also note that sometimes you will actually see that the baby does a tummy tuck, okay, like this. Flexing of the trunk the baby does. Tummy tuck it is called. That is actually a very favorable sign, good sign, because it would mean that the neck is getting flexed, the head is getting flexed, and it is descending into the pelvis. At this point in time, we start with the Morisot smelly wheat method to deliver the head once the nape of the neck is visible. So I'll show it to you here. Malar flexion, see, shoulder traction. Look at this, malar flexion and shoulder traction. Like this we have to perform, okay, right? So this is what we do simultaneously, okay, and try to lift the baby's body, not too much, right? You will not be able to actually lift it too much beyond 45 degree anyways, and that is all that is needed. And delivery of the head by flexion, delivery of the head by flexion. That is what is achieved in a breech vaginal delivery.